Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today, I'm joined by our deputy editor Nick Bostock.
Hello.
And our senior reporter Kimberley Hackett.
Hi everyone.
To talk about the key news stories affecting general practice. Coming up, we're looking at the government's 10-year health plan 1 year on and asking how much progress has been made, whether it's on track and what needs to happen next. As part of that, we'll be talking about PCN contract variations after every practice in Kent signed up to the first deal of this kind. We'll be looking at GP premises after NHS England chair Dr Penny Dash angered GPs after saying that GP practices have twice as much floor space as they need. And we're also discussing some of the challenges of getting new premises developments off the ground. And we'll be talking about whether or not the GP jobs crisis is beginning to ease as thousands of GP registrars prepare to qualify in the coming weeks. GP Online has joined forces with 5 essential healthcare resources to create the MIMS Healthcare Network. Since 1959, our Haymarket healthcare titles have supported primary and secondary care audience across the UK through individual publications and specialist events. We're now entering an exciting new era with the launch of MIMS Healthcare Network, linking together our 6 leading media brands to serve the entire healthcare community as one. The MIMS Healthcare Network covers GP Online, GP Business, MIMS, MIMS Learning, MIMS Learning Live and MIMS Pharma. By bringing together these resources, we aim to provide a seamless experience for all healthcare professionals and the organisations that support and supply the UK health sector. The MIMS Healthcare Network, covering every aspect of primary care. For more information about our subscriptions, visit GPonline.com/subscribe. So Nick, we're just past a year into the government's 10-year plan and you decided to have a look at how things were going and what the plans have meant for general practice so far. Just on a very broad level, what did you find? What did people tell you about how they think things are going?
Some GPs would tell you there's been some progress. Others would say there hasn't been much at all. But there's a fair bit to unpick, basically, because a lot has happened over the years since the 10-year health plan came out last July. There are a couple of things the plan promised that we would have expected to see by now. An updated NHS workforce plan was meant to come out by the end of last year, but still hasn't surfaced, and it could be a big deal for general practice. The existing plan would have grown hospital doctors 12 times faster than GPs, so will a new version reset that and deliver more GPs? Will it overclaim about the potential impact of AI on GP workload? So some of these questions are all to be answered by that plan. Neighbourhood contracts promised in the 10-year health plan for single neighbourhood providers roughly the size of a PCN, multi-neighbourhood providers that are larger, covering populations of around 250,000 people. Those were widely expected by the end of last year. And then for the start of the current financial year, but those contracts also haven't yet appeared, even in draft form for consultation. The plan also spoke about integrated health organisations, or IHOs. That's the idea of top-performing hospital trusts taking on control of budgets, including for general practice, across entire regional health systems. Contracts for those organisations also haven't yet materialised, but several hospitals across England have taken the first step towards being able to become IHOs by achieving what's called advanced foundation trust status. So one concern GPs raised here is that the hospital-led vision of the future for the NHS may be developing a little bit faster while potentially those GP-led neighbourhood contracts have stalled. GP spoke also about the impact of massive NHS reforms and how those had slowed down change over the past year. NHS England is being merged back into the Department of Health and Social Care. ICBs have been cut back, many are merging, and GPs in some parts of the country said that meant very little progress had been made, particularly with neighbourhood development. Over the past few months, that instability has obviously been magnified by uncertainty at the top of government. The Health and Social Care Secretary who signed off the 10-year health plan, Wes Streeting, is not in the cabinet anymore. He's on the back benches. We have a new Health and Social Care Secretary, James Murray, but with Andy Burnham likely to be crowned Labour leader quite soon, that could well change again in the near future. Until the dust settles at the top of government, there's definitely a sense of uncertainty about whether the direction of travel will be exactly as it was when the 10-year health plan was published. I think one final point worth noting is that parts of the agenda set out in the 10-year health plan are very much at the core of changes GPs have seen on the ground. And in fact, some of the things that have been at the heart of the current dispute with government. The plan's 3 shifts that people probably remember, the hospital to community, analog to digital, sickness to prevention. On the first of those, even if neighbourhood contracts haven't materialised, the hospital to community shift is very much linked to the big push to expand advice and guidance this year. As for the digital shift, GP practices are now receiving about 8 to 10 million submissions a month via online consultation systems. GPs say that's driven up workload and it's forced them to divert clinicians' time away from face-to-face care. And that's a big part of the current dispute with the government. And on prevention, just this week, we've been reporting on a plan for ICBs to identify practices that need to improve on CVD prevention. There are also changes in this year's GP contract around obesity, for example. So that's all prevention focused. So there's some evidence that all 3 of the shifts are closely linked to what's being asked of GPs. And that in that sense, the vision set out in the plan is having an impact, even if some of those big promises haven't come through.
You've touched on neighbourhood health, and obviously neighbourhood health and the neighbourhood NHS is very much at the centre of the 10-year plan. What did people tell you about what needs to happen to really make this work on the ground? Was there a sense that this was starting to work and things were starting to get moving on that?
One of the GPs I spoke to was Dr. Andy Brooks, chair of the National Association for Primary Care, NAPC. And the NAPC is involved with NHS England in delivering the National Neighbourhood Health Implementation Programme. And that's rolled out neighbourhood models in each ICB across England. And what Dr. Brooks said was that there's some really good work going on at local level that is starting to have an impact. He would have liked, he said, to see more funding, more upfront investment in neighbourhood development, and he felt that there needed to be more pressure from the centre of the NHS for ICBs to really drive this change. And he felt that neighbourhoods have slightly slipped down the order of priorities in the NHS since the 10-year plan came out. But ultimately, he said there's no reason for GPs and other sort of local partners not to push ahead with neighbourhood development. His view was that GPs don't need to wait for contracts to come out, the single neighbourhood, multi-neighbourhood provider contracts. When they do, if they do, GPs and PCNs can decide at that stage if those contracts would be useful. But his view was that they're not essential for developing neighbourhood working. We'll come on to talk about this a bit more shortly, but Dr. Brooks mentioned the fact that ICBs can now request variations to the Network Contract Directed Enhanced Service, the contract that governs practices' involvement in PCNs to support neighbourhood working. And he said that where PCNs and GPs have already begun to develop neighbourhood working, that ability to vary PCN contracts could be a useful tool to embed those changes. So that's one view, but another is that the government hasn't yet provided the kind of clear vision of what neighbourhoods are expected to do for GPs to get on with rolling them out. The RCGP told me that the focus needs to shift to practical implementation now, and that GPs basically need clarity on some key points. Which patient groups and clinical pathways should be prioritised? How care will be redesigned around patients' needs? How neighbourhood working will improve continuity, coordination and outcomes? Another key point the college made was that neighbourhoods won't work unless they're built around a strong, sustainable model in GP practices and the continuity they provide. So there's a warning there about the need to invest in existing general practice as the base to build from.
Like you said earlier, we've been waiting for these neighbourhood contracts for over a year now, and there's still really no sign of them. Is there any idea about when these are coming and what they could look like?
The government said it will consult on neighbourhood contracts this summer. But previous deadlines have come and gone, so we'll have to wait and see whether this one's any different. In the context of a potential new Prime Minister, potential new Health and Social Care Secretary, for example, is there a chance that deadline could slip, given we're already halfway through July? But in any case, that summer deadline is only for a draft version for consultation. Consultation might then run for 2 or 3 months, and then changes need to be made, talks have to take place to finalise them. And one lawyer I spoke to suggested it might not be possible in the end to get those contracts ready by the start of the next financial year, so by April 2027. So they could still be a fair ways off. In terms of what they'll look like, again, we'll have to wait and see, but there's been speculation about what single neighbourhood contracts could mean for local enhanced services, which are a key part of general practice income. Will those contracts strip out funding that currently goes direct to individual practices and shift it to a larger scale model? And what would that mean for the sustainability of existing practices? So some big questions around how all this will play out.
We've talked on the podcast before about PCN contract variation. So this is the ability that ICPs have had since May this year that means they can vary part of the network contract directed enhanced service, or DES, which is the contract that governs how PCNs work, to help facilitate neighbourhood working. The first part of the country looking at this is Kent. And Kimberley, you wrote a story last week about the fact that every practice in the county has signed up to that DES, didn't you?
Yeah, so that's 175 practices across 45 PCNs have actually signed up to take part. And it's expected that practices in the area will deliver additional support to around 92,000 complex and frail patients. Now, under the scheme, practices will be expected to provide advanced care planning and structured medication reviews, and practices will be expected to carry out these assessments for a minimum of 80% of their frailty cohort. And the cohort will be tracked, and the plan is that there will be a reduction in projected growth of hospital A&E admissions among this group.
And we have a bit more detail this week about what that contract variation involves in terms of funding, didn't we?
So I was able to speak with Kent LMC Chair Dr. Gareth Gupta about the contract in more detail. Now, first of all, the total funding of the scheme comes to £13.5 million. Of this overall funding, 9.9 million is new money, which was not previously available to general practice, and part of the 9.9 million is from acute trusts. So there really has been a left shift. The remaining £3.6 million is money that was once used for frailty-related primary care initiatives. And Dr. Gupta said that the area will need more staff to meet its targets, and he hopes that the contract change, which comes with a lot of funding, will see the recruitment of more GPs. Now, a big change in the contract is that PCNs will receive upfront, on a monthly basis, the full allocation of additional roles reimbursement scheme money. It means that practices won't have to go through the hassle of submitting reimbursement claims to the ICB, which we know can cause cash flow issues. Not only that, but practices will be given more flexibility as to who they hire under the Additional Roles Reimbursement Scheme, or ARRS. They will still have to hire mental health practitioners, for example, but many of the ARRS restrictions in the national DES have been removed under the local variation. In addition, funding will be available to practices based on their list sizes, and then there are some further payments based on the number of frail people at the practice. Now, if at the end of the year, the projected growth of hospital A&E admissions among the frailty cohort has reduced, then practices will also be given extra money.
Yeah, it's some interesting detail there, isn't it? I think particularly that ARS money being given up front to PCNs, I think lots of people would welcome a change like that to how that scheme works. Nick, you spoke to some lawyers recently about these contract variations as well, and they suggested to you that quite a lot of areas may be looking at this option for developing neighbourhoods in the absence of those contracts we were talking about. What did they tell you?
So far, Kent and Medway is the only area to have requested a variation to the network contract DES and to have had that approved. So we've been trying to find out whether other areas were likely to follow suit anytime soon. I spoke to lawyers at a couple of firms, Hempson's and DRR solicitors, and they told me that they were aware of PCNs that had started talks with their ICBs about potential variation to the DES, but that they weren't aware of any that had gone further than that and actually progressed to, formally submitting a request to NHS England to make a variation. So other areas are looking at how to use this option to vary the DES, but it doesn't look as if we'll see massive uptake in the immediate future. One of the lawyers, and they're both primary care specialists, said they expected over time that a few local variation templates effectively would emerge that ICBs could choose from. So essentially, there won't be endless varieties of variation. It may be more like a handful of templates that are tweaked a bit locally to suit the needs of different areas. One of the lawyers said ICBs looking at changes to the network contract DES to try to embed a more consistent approach across their patch. So ICBs have often inherited variation in services that practices provide, either because of differences between CCGs in the past or more recently as separate ICB areas merge. So variation in the types of local enhanced services and funding for them, to be fair, that goes to GP practices. And my understanding is that the Kent variation has been used to embed a consolidated service model across the ICB. And in parts of London, actually, all local enhanced services have been moved to PCN level already. So that could be the kind of approach we see from single neighbourhood contracts in future. But these areas are all emerging models that could become permanent in some areas, could be copied elsewhere, could be replaced down the track when other contract options become available.
The other big plank of the 10-year plan is obviously the tech side of things, the use of AI in particular. And there was a big announcement about that last weekend from the government and NHS England about a 10 billion investment in improving NHS technology, digital and data systems. Obviously, a lot of that money will be earmarked for hospitals, but the announcement also revealed plans to speed up the rollout of an AI triage tool via the NHS app. This was mentioned in the 10-year plan a year ago as one of the big developments for the NHS app. I seem to remember former Health and Social Care Secretary Wes Streeting said that the app would become like a GP in your pocket. And this triage system is quite central to that, isn't it, Nick? What do we know about that?
Upgrading the NHS app is a big part of the analog to digital shift in the 10-year plan as well. As you mentioned, Wes Streeting said it would become a doctor in your pocket. And he said that upgrades that the government was planning would take the NHS from a global laggard to a global leader in terms of health technology. The update we wrote about this week was that the government has decided to fast-track the rollout of an AI triage tool in general practice. And practice in Sussex had trialled this technology and found that it brought a 29% reduction in people queuing on its phone lines. And NHS England said that's a big step towards ending the so-called 8 a.m. rush, and that it had boosted patient satisfaction. So this tech basically ticks a lot of the modernisation, GP access boxes that the government's focused on. But there have been some concerns in general practice. The RCGP said a while back that the idea of referring to a triage tool as a doctor in your pocket, or my NHS GP was another name for it, I think, was misleading. Because even if it's useful, this technology isn't something that can take the place of a trained GP. I think there's also some concern that tools like this will be seen as an excuse not to invest in the GP workforce to the extent that's really needed. The 10-year health plan mentioned that AI scribes in general practice could save the equivalent of over 2,000 full-time equivalent worth of GP capacity. And GPs will want assurances that these tools are going to be rolled out to support them and not to replace them.
The other big part of that announcement about tech was about the rollout of AI scribes. And that NHS England press release suggested that the use of this tech was all focused in hospitals, really. That's what they were talking about, is rolling it out, accelerating the rollout in hospitals. But we know that many GP practices already make use of AI scribes and find them really helpful, although some don't like them. But I think if that tech is being rolled out really widely in hospitals, there'll definitely be some questions about funding this for GP practices. At the minute, most practices pay for this technology themselves out of their own funding, their own profits. I mean, in some areas there may be a system where ICBs fund a bit of this, but largely practices pay for this themselves. And the BMA has argued for some time that the government should provide funding to practices to cover these costs if it's really keen for them to embrace this technology. And I think there really will be a lot more questions raised about that if the NHS is deploying this tech really widely and at scale across secondary care and providing hospitals with the funding to enable them to do that, and they're not doing the equivalent in general practice. So I think that's going to be an interesting thing to watch over the coming months.
I think we had some polling recently that showed about a third of GPs possibly were using AI scribes. So if it's that widely used, then clearly it's a thing that a lot of people find useful, and therefore the idea that the government ought to fund it seems to follow from that.
So let's talk about premises. Nick, we mentioned spending on technology there, but that funding is part of a 10-year capital plan for spending on the NHS that the government actually announced in full this week. That announcement included some details about funding for premises. What did the government have to say about that and general practice?
Overall, the capital plan promises record capital funding for the NHS. rising to £15 billion a year by 2029-30, which is some ways off, obviously. Part of this is aimed at general practice, and there was an update on that from the government this week. We've reported previously on a £102 million block of funding aimed at GP premises upgrades in 2025-26. That's the financial year just gone. And that's known as the Primary Care Utilisation and Modernisation Fund. Some of the details around that fund have been a bit elastic. The Chancellor said in October 2024, so that was part of a budget announcement, that £102 million would pay for around 200 GP premises upgrades. Then in May last year, the government said the money would pay for more than 1,000 upgrades to GP premises, and that it would create space for about 8.3 million extra appointments. What we found out with the capital funding announcement this week was that the £102 million was actually spent on fewer than 800 upgrades in the end. So it's more than the 200 originally, but it's a lot less than the more than 1,000 that the government was talking about in May last year. And I'm told that this was because of an active decision to focus on fewer, larger upgrades, and that the funding available was spent in full. So that £102 million has all gone into general practice premises upgrades, apparently. Interestingly, the government said the 800-odd upgrades had created space for an estimated 9 million extra appointments. So that's more than the figure it said last year would come from just over 1,000 upgrades. I don't know how the maths works on that exactly, but presumably it's to do with additional rooms and the idea that there's more space in practice to provide appointments. Next question around that would be, are there enough GPs to fill any of those additional rooms? The government also said this week that a further £200 million would be available to help more GP surgeries expand and modernise. So that's not actually new funding. The government said back in February that it had committed £426 million over the next 4 years to continue upgrading the GP estate. And the £200 million announcement this week is part of that. So this money is going to be available over 4 years, the £200 million, available over 4 years, starting from the current financial year, and it's £50 million a year that's on offer. The plan also confirms that the government is going to be pushing ahead with proposals to roll out 250 neighbourhood health centres by 2035. 120 of those are due to be in place by 2030, and we know that of that £426 million estate funding, up to half is going to go on developing 40 to 50 neighbourhood health centres during the current Parliament.
We know that premises are a real challenge in general practice. We've talked about it a lot on the podcast. Do you think this capital plan goes far enough to address the concerns that GPs have about the poor state of the buildings many of them are working out of?
GPs have said from the outset that the £102 million fund for premises development was a drop in the ocean. I think the BMA said last year that it was barely enough for a handful of new surgeries. So although funding is welcome, this is very much not on the scale general practice needs. Last year, BMA polling found that half of GPs said their practice premises were not fit for purpose now, and 83% said their premises were not fit for future needs. And then 3/4 said they didn't have room to train new GPs. So, to be fair, on that point, not having room to train new GPs, perhaps this new funding, if it has created the space for additional appointments, additional rooms, it may have gone some way towards creating some of that space. But in any case, soon after the current government took office, you might remember that Lord Darcy, in a report that he produced at the behest of Wes Streeting at the time, he said that a fifth of the GP estate predates the NHS. So that's the scale of the challenge, and investment in upgrades on the scale being offered at the moment just looks unlikely to go far enough.
Kimberley, you actually wrote a couple of really interesting stories over the past couple of weeks about premises. One was about comments from the NHS England chair, Dr. Penny Dash, that really incensed GPs. What did she have to say that made them so cross?
So she was speaking at the Company Chemists Association conference, and she was talking about how NHS England is looking into how estates can be used to support neighbourhood models. And she seemed to suggest that there is more free or empty space space in general practice than people realise that could be used for out-of-hospital care. So she started off by saying that there is twice as much floor space in GP practices and associated services than they need. She then went on to paint a really interesting picture that general practices are really busy between 8:30am and 11am, and then between 3:30pm to 6:30pm, Mondays to Thursdays. Then she said that outside of those hours, GPs are often out of their practices doing patient visits. Therefore, the practice space isn't being used, and by de facto, as she puts it, practices aren't full up. But she didn't stop there. She even went on to say that fewer people are going into general practices for appointments because GPs are doing such a good job of triaging between 8:30am and 10am, and more appointments are being carried out over the phone. Her point was that if there is going to be investment in new or refurbished facilities for neighbourhood health and out-of-hospital care, then the money has to be used in an efficient way. And she believes that staff need to think differently about how they manage space in general practice. She said, if you spend a day in general practice just observing the going-ons, then there is actually more space for extra staff than it may seem in the first place.
Honestly, that statement is just incredulous, really, isn't it? I mean, there were so many GPs on our Facebook page commenting that it bears no relation to the reality of day-to-day working in general practice. I mean, I've spoken to so many people over the years who say that premises is such a major problem for them. Sorting out room rotas takes up hours of managers' time each week. And I think, it's a bit disingenuous for her to talk about people having to look at different ways of working, because I think most practices have looked at this. Loads of GPs and practice managers I speak to, they already have portions of their workforce that work at home when they can to free up space. What did GP specifically say about these comments?
Yeah, so her comments were put to GP leaders during a House of Commons Health and Social Care Select Committee meeting that was specifically about estates and delivering a neighbourhood health service. It probably comes as no surprise that the panel were not in agreement with Dr. Dash. One of the panel experts said they were flabbergasted by the comments and that it actually made her quite cross that such a picture of general practice was being portrayed. The GP leader also told MPs that staff at her practice have to have meetings in cars because there isn't a meeting room available. She also said that it's actually important to have some slack in the building so that practices can adapt for extremely busy days or make sure they have a room for someone who might be infectious. The RCGP Vice President for Member Standards, Dr. Jamie Hines, was also on the panel. Now, he responded with a raft of statistics that 64% of partners from the latest college survey said they don't have enough space to accommodate multidisciplinary team staff. And of 500 practice managers, 74% said they can't recruit because they have a lack of physical space. He said that practices have struggled to take on GP registrars because of a lack of space. And he said if there is any space in an overheated room where the server lives, for example, which isn't an ideal working condition at the best of times, it would be even worse for the recent heat waves we've experienced. So he said, any extra space is essentially non-patient facing.
I saw somebody on our Facebook page also saying, those comments about surgery rooms only being used between certain hours. Someone was saying, well, I am in that room in those other times and I'm doing all the masses of paperwork I have to do. So it's not like people are in there doing nothing at all, twiddling their thumbs. The other story you wrote about premises recently shows some of the problems GPs are facing in getting building projects off the ground, doesn't it? So this was based on an interview you did with the Lib Dem MP, Layla Moran, who's the chair of the House of Commons Health and Social Care Committee. She's the MP for Oxford West and Abingdon, and there's a practice in her constituency that's having real problems trying to get a new building to cope with increased demand because of house building in the area, isn't there? What's going on there?
So a practice in her constituency, the ICB and the local authority have all agreed that a new building is necessary to accommodate the increasing population after 5,000 new homes were built in the area. The current GP practice is spread over 3 floors in a Victorian building and there isn't any disability access on the higher floors. Now, Layla said that the practice offers a brilliant service, even with an old-fashioned building, but, it wants to do more and train even more GPs, but it can't because there is a lack of space. There are actually a couple of barriers to the new building being built. First of all, there's been a struggle to fund the new build, and the ICB even asked Layla if she knew of any other pots of available money to help fund the build. But the biggest barrier is down to the NHS's rent reimbursement scheme, where a district valuer decides how much a practice can claim for a premises. In this case, the district valuer has valued the potential new build's rent lower than the builder's estimated market price. So at the moment, it's a no-go on the new build that the practice, the ICB and the local authority have all agreed needs to be developed for the increasing population.
I don't think they're the only practice in the country experiencing problems like that. Actually, I met a GP recently in a different part of the country who was it sounded like they were having exactly the same scenario. And Layla Moran told you that lots of other MPs have practices in their constituencies experiencing these problems, didn't she?
She did. So she actually thinks that most MPs would have similar stories. She highlighted that one of her MP colleagues in another area also has been faced with a new housing development. Now, as part of the planning application, the council said the developer could build houses as long as a new GP surgery was funded. Now, the houses have been built, but the field for the surgery currently sits empty. And it's because they can't find a developer to build the surgery because the district valuer says that the amount of rent the ICB is allowed to reimburse the GP practice is significantly less than what the developer feels is market rate.
I think some of these problems around district valuer valuations and the way notional rent works, full stop really, could potentially really hamper the development of new buildings to support neighbourhood health as well. I mean, this was something that came up in a recent podcast that I did with Dr. John Ribchester in Whitstable, Kent. And that's an area that's often held up as a real success when it comes to neighbourhood working. And one of the reasons that area has been so successful at shifting services outside of hospital and into the community is because the GP practice decided to fund and build a new building that was big enough for them to accommodate these services. But then there's been all sorts of challenges with the rent reimbursement that comes with that because that space is not being used for general practice services. And I think it's really difficult as well to see how that left shift of services can really happen without GP practices or PCNs having access to additional space to accommodate these services, whether that's in their own premises or a different building or a new build neighbourhood health centre. And this came up in another recent podcast, which you can also listen to, with Dr. Emma Watts, who's the chair of the RCGP's Rural Health Forum. Rural areas in England are really very unlikely to get one of these new neighbourhood health centres. So the only way you can shift services out of hospitals into communities in rural areas is to invest in GP premises and ensure the space in existing GP buildings to house those services. I'm not sure that new capital fund that Nick was talking about really takes account of that. I don't think it's really clear that there is funding coming to enable those sorts of developments to happen. Moving on, let's talk about jobs. We're almost in August now, which is when many GP registrars receive their Certificate of Completion of Training, or CCT, and become fully fledged qualified GPs. Obviously, over the past few years, we've been reporting extensively on the GP jobs crisis, which has seen jobs for qualified GPs dry up as many doctors struggle to get a post or find the amount of work that they need. Unsurprisingly, newly qualified GPs have been particularly hard hit. In the last 2 years, we've seen the addition of GPs to the Additional Roles Reimbursement Scheme in a bid to tackle the problem. And this year saw the introduction of the Practice Level GP Reimbursement Scheme. Kimberley, you've been looking at what the situation is like for GPs due to qualify in the coming weeks this year. What did you find? Is it better or worse than previous years?
I spoke with one of the RCGP GP registrar co-chairs, and she told me that from what she's heard, the job situation for GPs about to CCT is pretty similar to the survey results the college released last year. So basically, people are finding work, but it's not enough. Essentially, there is a lot of underemployment.
One interesting thing that came out of those conversations that you had with people is that GPs are now having to join waiting lists to get work. How does that work?
Yeah, I mean, it's definitely a new issue that I've come across. So we know that due to a lack of funding, a lot of practices can't offer full-time work like they once used to. So the college told me that many registrars that are about to qualify and have been offered work, either short-term or part-time, have also been added to practice waiting lists to pick up more sessions when they become available. The college said that this is actually happening frequently.
You actually spoke to people in different parts of the country, and the picture isn't uniform across England, is it? Some people you spoke to said the job situation was a bit better this year compared with last year, didn't they?
They did, but only a little bit better. It's a varied picture for sure. So GP trainers from Manchester, Leeds and Liverpool told me that there are now more jobs available in their areas this year in comparison to the same time last year. However, in Manchester and Liverpool, the jobs aren't necessarily full-time work. Many of the GP roles are part-time, and registrars set to CCT are having to cobble roles together to make up full-time employment, which, for some people really isn't ideal. And in Northumberland, the LMC chair said he believes that the job market has actually got worse for GP registrars in his area, whereas Derbyshire LMC's chair, who is also a GP trainer, said she knows of fully qualified GPs who have been looking for roles for months, and some have now moved to Canada for work, and others are looking to train in different specialties because of the lack of work in general practice. The market isn't looking too good for registrars set to CCT in August. She criticised the government's lack of workforce planning, saying that it's great that there are more training places, but there really should be more funding into core general practice to employ registrars once qualified.
Have those two reimbursement schemes helped the job situation at all? I mean, it doesn't really sound like it from what you're saying there.
Not in terms of offering full-time roles. So they have helped in that there are more jobs being advertised. Recently, Nick did a story saying that around half of growth in the GP workforce over the last financial year came from jobs created through the ARRS. But, GP registrars and trainers have told me that the big issue is that many of those jobs only offer maybe 3 or 4 sessions a week. And as I said earlier, understandably, many people want full-time work.
Nick, this is interesting, isn't it? Because you wrote something this week about the explosion of portfolio working, and this is definitely a trend we've seen over the last decade, with more and more GPs having more than one role. In part, it's because working full-time in general practice has become so much more challenging and demanding, and part-time hours in general practice are often the equivalent of a full-time job in any other sector. But it's also because GPs want to spend some of their week doing other things, be it teaching, training, appraisals, working in a hospital, specialty, all sorts of things. One of the attractions of general practice. But some of what Kimberley has been talking about suggests that newly qualified GPs may be being forced into this way of working, even if they don't necessarily want it. So rather than it being a choice, it's just actually something that becomes a necessity if you want to get enough work.
The survey I wrote about found that 2/3 of UK doctors and 3/4 of GPs now have portfolio careers. And there wasn't a GP-specific figure on this, but across all doctors, there was a really significant rise in the proportion working in portfolio roles. Lots of GPs, like you said, have always worked in portfolio careers, have mixed things up because it can allow them to mix working with patients, with research, teaching, or specialist work. And often, as you touched on, it's exactly that ability to mix things up that GPs say makes the job interesting, keeps them happy. The polling I looked at from a financial service provider called Wesleyan also found that half of GPs are doing some private work. So we're not just talking about teaching or research. This is also about work outside the NHS. And that can reflect a mix of factors such as dissatisfaction with pay, the rise of private, often remote GP services that are looking for NHS-trained GPs to work for them, as well as potentially a lack of available work in NHS roles. And that's some of the stuff that Kimberley was touching on earlier. Lots of GPs had taken on other roles, according to this survey, because they felt it was a good way to escape the pressures of working full-time in frontline general practice, or just as an opportunity they felt would help their professional development. So portfolio working is often a positive choice and something that can support GP retention. But the survey also found just over half of GPs had considered moving back to a single role, often because managing multiple jobs was difficult. And that maybe speaks to the point Kimberley made about some GPs being pushed into portfolio ways of working, perhaps in part, again, because of this shortage of jobs available in recent years.
That's interesting. I don't know if people have seen, we're running a series of special bonus episodes of Talking General Practice, which we're doing in partnership with Wesleyan, called GP Money Matters, and you can find them on the podcast feed if you've not heard any of them. There will be an upcoming one in the next month or so about exactly this, about portfolio working and what it means for your personal finances, and we'll be talking about some of the findings from this survey as part of that, so keep an eye out for that. Well, that's it for this week. Thanks to Nick and Kimberley, and thank you for listening. I'll be back next week when I'm speaking to organisational psychologist Dr. Ruth Abrams, an associate professor at the University of Surrey School of Health and Sciences, about her recent study into the conditions that help women GPs thrive in general practice. It's a really fascinating conversation, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.